Okay, so Dr. Filippo Varese, our keynote speaker, welcome. Chers collègues et amis du département de psychologie et surtout chères étudiantes et chers étudiants, c'est avec immense fierté et honneur que je participe à cette 16e journée scientifique du département de psychologie à titre de professeure et de directrice du département. Cet événement, c'est vraiment un lieu de rassemblement scientifique annuel des plus importants pour notre département. De nombreux membres de notre communauté étudiante départementale ont l'occasion aujourd'hui de présenter leurs travaux de recherche, de se familiariser avec le monde de la recherche. Et pour plusieurs, c'est vraiment une première expérience de participation à un congrès, un colloque. Cette année, on a eu le grand plaisir de voir, d'entendre, d'écouter 115 communications scientifiques. Donc, bravo à toutes et à tous. Cette 16e édition aussi a lieu pour la première fois en présentiel depuis 2019. Donc, on est vraiment très, très content de se retrouver en face à face. Et aussi, cette journée a lieu dans le cadre de notre 80e anniversaire de département que nous avons célébré tout au long de l'année. Donc, on a accueilli aujourd'hui près de 250 participants au cours de la journée à cette journée scientifique et aussi plusieurs diplômés assistent à cette conférence et des diplômés ont aussi été très nombreux à participer à nos conférences du 80e. On a offert 9 conférences du 80e anniversaire cette année, donc plusieurs diplômés, plusieurs étudiantes et étudiants ont participé. Alors, merci d'avoir été parmi nous. Et ce n'était qu'un début de reprise de contact avec nos diplômés et beaucoup plus d'activités en ce sens à venir dans les prochaines années. Donc, je vais être brève et laisser le soin aux dignitaires de dire de bons mots à l'endroit de nos étudiants et de notre département et aussi du rayonnement de la recherche qui se fait. Je vais me contenter de dire que, comme vous le savez, vous le vivez, la recherche occupe une place centrale dans notre département, dans nos programmes de formation dès la première année du premier cycle. Cette valeur est profondément ancrée dans la philosophie d'encadrement des professeurs du département et aussi dans les objectifs de formation de nos programmes. Donc, quelques chiffres. Dès le premier cycle, plus de 400 étudiants participent chaque année à des activités de recherche siglées dans le cadre de leur baccalauréat en psychologie ou en neurosciences cognitives. À cela s'ajoutent les travaux de recherche de quelques 450 étudiants au cycle supérieur, dont 80% sont au doctorat. Alors, je souhaite souligner tout le dévouement et le travail qu'implique l'organisation de cette journée à chaque année. Je remercie mille fois le chef d'orchestre, Ghislain Giguère. Je pense qu'il est en train de compiler les heureux gagnants des prix de présentation. Et donc, c'est Ghislain, le chef d'orchestre, qui mène toujours à bien cet événement. Et il était accompagné cette année du comité organisateur qui incluait les étudiants Émilie Giguère et Amélie Lévesque, Inès Sanchez aussi, analyste, Floriane Louisin, qui est responsable de la gestion financière au département, ainsi que le professeur Maxime Paquet et moi-même. Donc, on peut aussi compter sur l'appui de nombreux bénévoles, étudiants et professeurs pour évaluer les présentations des étudiants et aussi pour assurer le bon déroulement des présentations orales, entre autres comme modérateur. De nombreux partenaires pour cette journée méritent aussi toute notre attention et nos remerciements. On a plus de 35 partenaires qui ont contribué à rendre cette journée possible. Ça nous permet aussi d'offrir 4 500 $ en prix aux étudiants pour vraiment les féliciter pour leur présentation. Et aussi, on aimerait remercier le réseau des diplômés, des donateurs qui nous permettent de contacter via les listes nos diplômés pour pouvoir assister à cette conférence. Alors, je vous invite à rester parmi nous après la conférence pour la remise des prix aux étudiants, mais aussi pour la remise des plaques aux gagnants de notre concours du meilleur enseignant et de la meilleure enseignante. Et sur ce, j'invite le professeur Yves Joannette, vice-recteur adjoint à la recherche, à la découverte, à la création et à l'innovation, à vous dire quelques mots.
Merci beaucoup, Michel, et vraiment félicitations pour une journée remarquable au vice-rectorat à la recherche, découverte, création, innovation. Vous voyez la séquence des choses. Hein? Ça veut dire qu'il y a un impact à ce qu'on cherche et qu'on finit par découvrir un jour sur la société. Eh bien, on est très fiers du département de psychologie. C'est un département qui est certainement très performant au niveau canadien, au niveau québécois, c'est sûr. Et c'est un département qui a vraiment toute une histoire. Donc, vous terminez cette année vos 80 ans. C'est une période... alors là, je vais me tirer dans les pieds moi-même, mais dont j'ai connu à peu près la moitié en tant que professeur et directeur, superviseur, jusqu'à aujourd'hui d'ailleurs, d'étudiants, maîtrise, doctorat et post-doctorat. Et on voit la qualité incroyable de ce que vous faites. Alors, ce qui est extraordinaire à votre journée, c'est que c'est non seulement celles et ceux qui se vouent à la recherche, qui aimeraient se vouer à la recherche, mais c'est l'ensemble du département, premier cycle inclus. Et ça, c'est super important parce que la psychologie, je dirais, dans sa pratique, est une profession qui est basée sur la science. Et il faut être de bons consommateurs de recherche. Il n'y a pas moyen d'être un bon consommateur, consommatrice de recherche si on n'a pas fait au moins une expérience de ce que c'est la recherche. Alors, je vous souhaite vraiment une bonne conférence avec l'invité de Manchester, un piacere, Dr. Varese. Et vraiment, c'est une journée qui va être importante pour vous, non seulement pour écouter des choses que vous avez connues, vous l'avez déjà pratiqué d'ailleurs, il y a eu les communications affichées, d'autres communications, mais vous avez vu des choses. Et ce qu'il faut dans ces journées-là, c'est pas seulement s'intéresser à ce à quoi on s'intéresse d'emblée, mais aussi à s'ouvrir à ce à quoi on ne s'intéresse pas nécessairement naturellement. Parce que c'est comme ça qu'on fait des liens. Et c'est comme ça que le département de psychologie, ses équipes de recherche font aussi des liens avec d'autres domaines, d'autres secteurs, que ce soit l'intelligence artificielle, les arts, les neurosciences, etc., etc. Et c'est super important pour accroître l'intersectorialité, pas juste l'interdisciplinarité, mais l'intersectorialité. Et au vice-rectorat, c'est une dimension qui nous est très chère. Et je dois dire que c'est une dimension qui nous caractérise comme université, même au Canada et sur la scène internationale, l'emphase que l'on porte à l'importance de mettre non seulement différentes disciplines, mais différents secteurs en contact. Alors, avant de terminer, je vais simplement vous signaler une chose pour que vous le sachiez, c'est qu'au 1er mars, sans que vous n'en ayez pris conscience pendant que vous dormiez le matin, il y a un site web, une page web qui est apparue sur la page web de l'Université de Montréal et qui publie ce qu'on appelle la stratégie institutionnelle de gestion des données de recherche. C'est une obligation des 3 conseils subventionnaires et de l'ensemble des organismes subventionnaires. Donc, ça vous concerne vous en tant qu'équipe de recherche. Et il y a des exigences qui vont venir même au niveau des dépôts de demandes de subventions à partir de l'année prochaine, parce qu'il faudra déposer des plans de gestion de données de recherche. Alors, consultez ça. Soyez assurés que le Bureau de la recherche et du développement, le BRDV, sera en appui à ça, mais ça va faire sourciller certaines personnes quand, dans les préparations de demande de fonds, on va constater qu'il faut en plus planifier comment on va gérer, stocker, disséminer, partager nos données de recherche. Mais en bout de ligne, c'est très important parce que c'est comme ça qu'on va en faire profiter au maximum. Alors, merci et prenez note. Alors, excellente fin de journée, excellente fin de 80e. Et thank you so much for being here today. Grazie.
Oui, pour soutenir le fait qu'on est vraiment un département avant-gardiste, nous avons eu une réunion en assemblée départementale de la part des collègues des bibliothèques sur la gestion des données de recherche. Donc, tout ça tombe à point. Alors maintenant, j'aimerais inviter Louise Demers, professeure, directrice et vice-rectrice associée aux études supérieures et post-doctorales. Alors, bonjour tout le monde. C'est un honneur pour moi d'être avec vous cet après-midi. Individuellement, je connais quelques personnes parmi vous, mais je pense que collectivement, je vous connais un petit peu, puis peut-être même beaucoup.
En fait, c'est que le département de psychologie est connu pour offrir des formations vraiment solides qui attirent parmi les meilleurs. Et je sais que ces formations-là se déclinent vraiment de multiples façons, mais on m'en a fait la démonstration, là, toutes comprennent une partie substantielle d'activités de recherche. Alors, je pense que la journée d'aujourd'hui là, témoigne de façon très éloquente de la richesse là, des travaux qui se font avec notamment des sujets que j'ai trouvés là, étonnamment diversifiés, ce qui est, je crois, une marque là, qui témoigne là, de l'avancement des connaissances là, dans plusieurs sphères de la société. Alors, pour ma part, j'aimerais vous dire quelques mots là, sur les activités que je fais au niveau des études supérieures et postdoctorales, parler un petit peu de financement étudiant et de développement professionnel. Alors, d'abord, le financement, on sait, il va sans dire que le financement étudiant, c'est critique au cycle supérieur et actuellement, c'est largement insuffisant. C'est vrai dans une perspective institutionnelle parce qu'on veut contribuer avec le financement à attirer les gens en su là, de la qualité des professeurs, des programmes et aussi des laboratoires. C'est donc un élément qui s'ajoute là, et qui est très critique pour notre institution. Mais je pense que c'est encore plus vrai dans une perspective étudiante, puis là je pense aux étudiantes et étudiants qui sont ici. On aimerait que tout le monde ait la possibilité de se consacrer à temps plein à des études, tout en ayant une vie un tant soit peu équilibrée. On voudrait aussi que tout le monde puisse boucler la boucle de l'expérience universitaire dans des délais qui sont acceptables. Alors, sachez qu'on travaille très fort, puis en partenariat avec la faculté et le département de psychologie, pour aller chercher le plus de financement possible pour vous. Vous avez sûrement entendu parler de financement intégré. On le définit là, comme la combinaison de différentes sources pour assurer un soutien pendant toute la durée des études. Alors, ça peut comprendre des bourses, ça comprend aussi des salaires. Et la plus intéressante source de financement, à mon avis, ce sont les bourses des grands organismes subventionnaires, là, les fonds de recherche du Québec et les 3 conseils de recherche du Canada. Alors, ce qu'il faut dire, c'est qu'à ce niveau-là, le département se démarque nettement par l'excellence des candidatures qu'on a l'occasion de réviser, par le nombre d'octrois qui sont obtenus, et aussi quelque chose qui est un peu unique, là, c'est que le fait que les projets ici peuvent se retrouver sous les 3 grands termes là, qui sont, là, si on reprend la nomenclature fédérale, les sciences humaines, évidemment, la santé, mais aussi les sciences naturelles et le génie. Alors, c'est très... Ça aussi, ça en dit long là, sur la diversité des activités qui sont les vôtres. Ensuite, l'avenir est au développement professionnel et au développement de compétences transversales. Je pense que c'est une partie de la réponse pour se préparer au marché de l'emploi. Cette idée-là fait d'ailleurs assez consensus au sein des universités. Puis pour nous, à l'Université de Montréal, le défi, c'est d'intégrer ça en plus dans le cheminement au cycle supérieur. Alors, l'activité scientifique d'aujourd'hui, à mon avis, ça va exactement dans le sens que l'on souhaite. C'est une manifestation claire de l'importance donnée à la science, mais c'est aussi une manifestation de compétences en communication, en collaboration, en gestion et aussi en innovation et en créativité, et tout ça ne peut que vous servir dans l'avenir. J'aimerais d'ailleurs rappeler pour ceux qui ne le savent pas déjà que les ESP ont mis en place, il y a à peu près une dizaine d'années, un programme de développement des compétences transversales qu'on appelle les saisons des ESP. Ça repose sur 8 compétences qui ont été choisies justement là, pour leur lien avec l'intégration au marché du travail. Alors, le département de psycho se démarque ici aussi. Le département de psycho arrive en tête par rapport au nombre de personnes qui se sont inscrites à nos activités depuis les débuts. Alors, je vous encourage fortement là, à continuer dans le même sens. Alors, en somme, félicitations pour la tenue de cette journée scientifique, félicitations pour l'ensemble de votre parcours universitaire. Bienvenue au Dr Varese et je suis certaine que la présentation avec toutes les méthodologies que ça peut impliquer va intéresser tout le monde. Merci de votre attention. Bon 80e aussi et bonne fin de journée.
Merci. Donc maintenant, j'inviterai Andrea Schmitzer, vice-doyenne aux affaires professorales, partenariat et innovation de la Faculté des arts et des sciences, à nous dire un mot.
Merci beaucoup, Michel. Bon après-midi, tout le monde. Chers collègues, chères étudiantes, chers étudiants, Je suis très heureuse d'être avec vous cet après-midi, dû à l'indisponibilité du doyen, mais la chance est de mon côté. Donc, je suis très heureuse d'être avec vous lors de cette 16e journée scientifique du département de psychologie. Chaque année, les étudiantes et les étudiants du département de psychologie se prêtent avec fébrilité, enthousiasme et une petite dose d'appréhension à un exercice qui n'est pas toujours évident, mais très formateur. Présenter leurs travaux sous forme de communication orale ou affichée à leurs pairs et professeurs. Michel l'a mentionné, vous avez en cette 16e journée scientifique plus de 250 participantes et participants et 115 communications. C'est impressionnant. Chaque année, l'éclectisme des thèmes et la profondeur des questionnements qui sont abordés, ainsi que la vitalité scientifique dont fait preuve le département de psychologie, sont exceptionnels et impressionnants. Chères étudiantes et étudiants, grâce à cette journée scientifique, vous faites pleinement connaissance du monde de la recherche. En exposant les résultats de vos travaux de recherche et en assistant aux présentations de vos collègues, vous vivez finalement votre premier congrès scientifique. Ce forum de vulgarisation, de communication et de pédagogie est un remarquable exemple de la façon dont notre faculté, votre faculté, transmet les savoirs, ouvre la porte du monde des idées et nourrit la pensée critique. Michel l'a mentionné, un événement de cette ampleur nécessite la mobilisation de l'ensemble du département et du personnel du département de psychologie. Merci à tous pour votre implication. Vous permettez à cette journée non seulement de perdurer, mais aussi d'en être une très belle réussite. Un gros merci à tous ceux qui sont impliqués, et Michel compris. Au nom de la Faculté des Arts et des Sciences, j'aimerais également remercier Dr. Filippo Varese, qui vous présente une conférence au cours de laquelle il vous présentera ses recherches à propos du traumatisme et des psychoses. J'ai fait mes devoirs. Que ce soit du point de vue pronostic de l'épidémiologie, des méthodes de méta-analyse, des méthodes d'échantillonnage expérimental, des recherches qualitatives, des essais cliniques et des études d'imagerie cérébrale. Je vous félicite toutes et tous et je vous souhaite une excellente continuation dans vos divers projets.
Merci. Maintenant, j'invite Tania Lecomte à nous présenter notre conférencier.
Merci, Michel. D'abord, je voulais vous dire que j'aimerais ça être à votre place, tu sais, d'être dans le sens d'avoir la chance, dans le cadre d'une journée scientifique départementale, d'avoir une vedette qui vient comme ça d'Angleterre nous présenter ses résultats et qui touche à un thème qu'on n'entend pas beaucoup parler parce que c'est quand même, on peut penser que c'est spécifique la psychose, mais c'est rare qu'on ait des conférences ici au département sur la psychose et qui touche aussi au traumatisme. Donc, j'espère que vous allez avoir autant de plaisir que moi à découvrir ce domaine qui est absolument fascinant. Vous allez peut-être trouver bizarre qu'on parle de Filippo Varese, puis on s'est marqué qu'il vient d'Angleterre. Donc, oui, il est italien d'origine. Donc, il a fait ses études au niveau du baccalauréat à l'Université de Parme, en Italie. Par la suite, il est déménagé en Angleterre où il a fait ses études de maîtrise, doctorat et postdoc avec des sommités dans le domaine, le Richard Bentel et Toni Morrison, qui sont vraiment parmi les pionniers là, dans tout ce qui est la psychothérapie et les études, développement de thérapie pour les troubles psychotiques, entre autres les thérapies cognitives comportementales. Aujourd'hui, il est Senior Clinical Lecturer, c'est-à-dire professeur agrégé. Donc, on a vraiment une star montante qui va bientôt être professeur titulaire, je crois bien. J'ai évalué son dossier, j'ai de fortes chances. Il y a plus de 80 papiers dans des revues à très, très haut niveau d'impact. Dans les dernières années, il y a eu 12 subventions comme chercheur principal. En 2022, il a gagné le May Davidson Award essentiellement, c'est le prix le plus prestigieux du British Psychological Society pour la contribution dans le domaine. Donc, on a affaire non seulement à un chercheur, mais un psychologue clinicien. Il est directeur du Complex Trauma and Resilient Research Unit, donc qui est une grosse unité de recherche. Ses études touchent, oui, à la psychose, oui, au trauma, mais aussi au PTSD, au trauma complexe. Il s'intéresse aux réfugiés, aux femmes victimes d'agression, à la violence conjugale. Et comme vous allez voir, il touche à énormément de stratégies, de techniques, de diversité, de méthodologies de recherche. Il collabore aussi avec plusieurs personnes, là, beaucoup en Europe, mais un peu partout dans le monde. Il a travaillé aussi avec les entendeurs de voix, avec les personnes à ultra haut risque, donc des personnes qui n'ont pas encore développé un trouble, mais qu'on soupçonne qu'ils seraient à risque de développer pour faire de la prévention. Donc, on change de paradigme. On n'est pas dans un paradigme, les troubles mentaux graves, la schizophrénie, la psychose, ça fait partie de la psychiatrie, c'est des désordres du cerveau. On est vraiment dans un paradigme que, oui, il y a des influences psychosociales qui peuvent être importantes et peut-être même possible de prévenir des épisodes de psychose et de prévenir des rechutes. Son travail sur le lien entre le trauma et la psychose, en fait, a été en anglais on dit un eye-opener. Sa première grosse méta-analyse sur le sujet a révolutionné le domaine. Ça a fait en sorte que tout le monde s'est réveillé puis dit « Oh, OK, oui, le trauma est peut-être plus important qu'on pensait. Les histoires traumatiques dans l'enfance, ça l'affecte beaucoup plus qu'on pense au niveau clinique et au niveau du développement de différents troubles mentaux graves. » Il n'y a pas beaucoup de chercheurs qui s'intéressent à des domaines qui sont à la fois cliniques et développement d'intervention liés au trauma puis à la psychose comme il le fait, entre autres parce que ça prend énormément d'années recruter puis avoir des données. Et donc, c'est d'autant plus louable qu'il le fait présentement et espérons-le pour les années à venir. Et finalement, ce qu'on va voir un peu aujourd'hui, un petit clin d'œil, on va voir ces différentes approches méthodologiques, on va voir beaucoup de liens avec la psychose et le trauma, mais vous allez voir que beaucoup de ces recherches peuvent vous influencer, vous inspirer et peuvent toucher à d'autres domaines aussi et certaines des méthodologies, que ce soit au niveau numérique, des applications mobiles, les essais cliniques randomisés ou autres, vous allez probablement trouver que ça peut vous être utile. Même au niveau des méta-analyses, il a développé une expertise qui va au-delà de la méta-analyse simple, mais les individual patient data meta-analysis, etc., etc. Alors, écoutez, sans plus tarder, et c'est avec grand plaisir que je vous présente le docteur Filippo Varese.
Merci, Tania. Bonjour, je m'appelle Filippo, and that's all the French I know, I'm afraid. Actually, it's a little lie. I actually lived with 3 or 4 actually French students when I was an undergraduate student myself, but I better not to repeat the French word I picked up in that period, basically, are not appropriate for this context. So thank you so much to the members of the faculty for inviting me for this lecture today. As Tanya mentioned, I work in a lot of different clinical areas, but actually the topic of trauma and psychosis has been my, I suppose, my first academic passion, and one of the areas in which I continue to do quite a lot of significant work in collaboration with a lot, of course, of other people. Science is never the achievement of a single individual, it's the achievement of a community of people that help each other. And I had the privilege of working with a lot of mentors, like Richard Bentel and Toni Morrison that were mentioned before, a lot of excellent clinicians that really know how to work with very complex, highly traumatized clients, and also now with a lot of PhD students that are working in my own lab, basically. So the work that I'm presenting today is really the product of the hard labor of all these people, and there should be probably many more cited here, but also the trauma survivors that are taking part in our studies, and not just that, are actually guiding and are involved as co-researchers in a lot of the research that we conduct at the Complex Trauma and Resilience Unit in Manchester. I'm going to start with a little bit of a disclaimer, or a couple of disclaimers. First of all, about my conflict of interest, I suppose. I'm a researcher that is publicly funded by the National Institute of Health and Care Research, which is the primary funding body for applied health research in the UK. And a lot of my funded work is actually related to the topics that I'm going to talk about today. These are 4 of the currently ongoing or recently completed clinical trials. I'm going to mention them different points or different snapshot of these studies over the course of my talk. So of course, I must say I have a vested interest in this area. Yeah, for me, this is a very important area of healthcare provision development, basically, and I strongly believe on the importance of targeting and tackling the problem of trauma and psychosis. And this is my disclaimer of my position as a researcher on where I stand in relation to this topic. And it's actually, incidentally, the conclusion and the take-home message of my talk. And I'm going to start from there, basically. The first point is that for many patients, psychosis and trauma are inextricably linked. Yeah, they are very closely tied together. And we cannot understand truly the struggles of people with lived experience of psychosis unless we take into account their life experiences and their experiences of trauma. And ultimately, I believe that addressing trauma-related difficulties in people with psychosis should be core business of any mental health care professionals, basically. And hopefully, through the talk today, I'll give you a little bit of an idea of how I started basically developing these beliefs. Yeah, they are not delusional, in my opinion. So I'm going to start, for those of you that are not working in the area, with a little bit of an introduction to psychosis and trauma more generally. Yeah. So what is psychosis? Psychosis is a term used to describe unusual, unsettling, and at times confusing experiences that comprise both cognitive and behavioral and perceptual symptoms. Typically, we make a distinction in the symptom of psychosis. We talk about positive symptom of psychosis and negative symptom of psychosis. That doesn't mean that the positive symptoms are nice and the negative are not. Positive means these are experiences that are present in people with psychosis, but assumed to be absent in the general population or in people without psychosis. So experiences such as hallucinations, paranoia, delusion, thought disorder. Negative symptoms are deficit in certain capacities of the individual that are assumed to be present in people without psychosis, but diminished in some way in people who receive a diagnosis of a psychotic disorder. So avolition, for example, lack of motivation, or difficulties in expressing appropriate affects, for example. So psychosis is assumed to be a characteristic feature of schizophrenia and psychosis-related disorders, but is actually present in a whole range of other psychiatric diagnoses. So, for example, bipolar disorder, borderline, and also it's present in a sizable minority of the general population. So a lot of people out there hear voices of have unusual beliefs, but these are not necessarily very intense or associated with distress and need of care. There are much more people in the general population with psychotic experiences than there are patients with diagnosable psychosis. The peak onset of psychosis-related difficulties when these experiences become troublesome for people is actually in late adolescence and early adulthood. So approximately in the majority of studies between the age of 20 and 24, although psychosis can occur at any point over the person's lifetime. And the important point, and I think actually Tanya already mentioned this to some extent in her introduction, psychosis does not develop out of the blue. It is generally preceded by a prodromal period, a period when people are already starting to experience unusual perception, unusual beliefs, but these are not meeting yet a diagnostic threshold, and they might foreshadow, if we follow these people up over time, a future full-blown episode of psychosis. Yeah, and it's now possible actually to identify these people with these prodromal signs of psychosis using a number of clinical instruments, and we call this group the ultra high risk for psychosis group, or UHR, and this is a group that I'm conducting quite a bit of work with, basically. After a first episode of psychosis, prognosis for people with lived experience of psychosis are variable. Many people recover after a first episode. They have a first episode and they are okay for the rest of their life. But as still a very large number of people might continue to struggle with these difficulties for a very, very long time. So it's very important that we continue to understand better the causes of psychosis, the factors that exacerbate psychosis, and develop better treatment for this group. And I think trauma is one of the important factors that we need to take better into account. So what do we mean by trauma? Actually, trauma is actually quite a tricky term, and because it's used in the literature in a very ambiguous way, or at times to indicate different kind of concepts. So one first connotation of the term is actually to indicate exposure to adverse events and circumstances that are experienced as harmful or life-threatening, and that have lasting effects on the mental, physical, emotional, and social well-being of the individual. But at times the term trauma is actually used also to indicate specific psychological reactions to adverse life events that can lead to a range of symptoms and difficulties. So the typical one that most of you will be familiar with is post-traumatic stress disorder. So during my talk, actually, when I use the word trauma, I will use it in relation more to the first connotation of the term, exposure to adverse life events and circumstances. However, a lot of the evidence that actually I'm providing to you today is actually trying to reframe, at least in some cases, experiences of psychosis as a reaction to traumatic life events, basically. So it's related to the second point. So actually the question of whether trauma might be involved in the development of psychosis is not new. It's been around for a long time, and it's been controversial for many decades. But it's only until relatively recent time that the mental health research community has taken this topic seriously and has started to apply research methods that help us to understand better the complexity of this problem. And exactly in the same way in which, a prism is able to decompose a beam of light into its constituent components, research is actually, and different research methodologies are helping us to understand these complex phenomena and break them down into more specific, more molecular, if you want, research questions that, when puzzled together, are actually helping us to understand, with a little bit more depth, a little bit more nuance, basically a complex research phenomena. Yeah. And so, for example, different research methodologies can help us to understand different important features of the relationship between trauma and psychosis. So, starting from basic questions. Is trauma more common in people with psychosis compared to healthy control? Does it represent a risk factor for the future development of psychosis? Does experiencing trauma influence the long-term prognostic outcomes of people with psychosis? What psychological, emotional, brain mechanisms perhaps might be at play to explain this relationship? And also, can we use psychological intervention to change the state of affairs? Can we use psychological intervention to target trauma-related mechanism and improve clinical outcomes for people with psychosis? And all these different levels of analysis, if you want, can be actually tackled with research methods, research design, statistical methodologies that you are starting to learn as part of your undergraduate and postgraduate studies. Starting from case control studies up to much more sophisticated statistical method and analytic approaches. And this on this slide is a little bit of a summary of the different methodologies that I was able to play with over the years in collaboration with multiple both methodologists and other researchers that have expertise in this area. And today I'm going to try to give you a little bit of a flavor of how these different methods can actually help us to understand complex research questions like, is there a relationship between trauma and psychosis? And I'm going to start with an aggregation of a lot of these different questions. And it's actually whether we can regard trauma as a potential risk factor for the development of psychosis. So this is a question that can be tackled in multiple ways, but of course, the easiest approach, the first approach that we can take, is taking a sample of people who have received, who have attracted a diagnosis of psychotic disorder and a control sample, typically an healthy control sample, and ask them about their life experiences, using both perhaps unstructured instrument or specific questionnaires that have been used to assess for trauma, especially traumatic events that might have happened to them before the onset of psychosis, so typically in childhood. So this is essentially a case control design. Yeah, and these are very well suited to examine questions related, for example, to whether experiences of childhood trauma are actually more common in people with psychosis compared to alleged healthy individuals in the taken from the general population. There have been a number of studies of this kind over the years. In this slide is an example of one I did during my PhD. This investigation has typically found that indeed levels of exposure to traumatic events like childhood sexual abuse, physical abuse, neglect, etc., are elevated in people with psychosis compared to gender and age-matched control, basically. And not only that the level of traumatization in patients seems to be associated also with the severity of the symptom of psychosis they present with. The more trauma exposed they are, the more severe their symptoms are. Yeah. Of course, there are a lot, as you know, a lot of limitations with this kind of research design. And one is, first of all, are these data, are these findings actually representative of general population kind of samples, basically? And fortunately, there are a lot of different, national data sets available worldwide, and there have been for a number of years, that are helping us to tackle effectively the same research question using large-scale epidemiological data set. So effectively cross-sectional studies that are sampling individuals in a way that then the finding could, with some adjustment, be seen as representative of the general population that you try to sample. So this is another example of a study of this kind that I've done quite early on in my career with Richard Bentel, in which we analyzed the data from a large-scale survey called the British Adult Psychiatric Morbidity Survey. And again, we replicated effectively the same finding. When people are exposed to adverse childhood experiences, their odds or the likelihood of experiencing symptoms of psychosis like hallucinations and paranoia increased. And this is a general population kind of findings. Of course, these are still cross-sectional data. Yeah, and we all know that there are problems with this, with the analysis of cross-sectional data. It does not help us basically to potentially make a step further towards inferring causality until we establish some level of temporal association. Yeah, so effectively trying to understand whether trauma predicts the onset of psychotic experiences prospectively by following people up over time using a prospective study. And oops, what have I done? Here we go. And actually, when we started, when I started getting interested in the area of trauma and psychosis, a lot of research in this area was taken very skeptically by the psychiatric community because of the lack of longitudinal data. And a lot of people actually cited this specific longitudinal study by Spataro, which followed up a group of trauma-exposed children exposed to sexual abuse over time, and found evidence of an association with the increased mental health difficulties in a lot of different domains, but not psychosis. Yeah, the problem with this study and a lot of or several other longitudinal studies that were available at the time is actually that they didn't follow up people for a sufficient number of years. And actually, when the same research group tried to replicate the analysis, tried to replicate the analysis in an expanded sample, in a sample actually that was followed up for longer after people actually reached the point of peak onset for psychosis, they actually found evidence of an association between trauma and psychotic disorders and psychosis more generally. Yeah, this is not research I conducted, but was available at the time. There was when I started getting interested in this area, more and more studies started to pop up, some confirming the relationship between trauma and psychosis, and some actually reporting, that the relationship was not statistically significant. So actually, as Tanya mentioned earlier, we decided actually to do an important piece of work in this area by conducting a meta-analysis, the first meta-analysis of this research literature. So several of you are familiar with what a meta-analysis is, and I became a big fan of meta-analysis over the years, basically, but it's essentially a family of statistical methods that enables to aggregate and compare the findings of different quantitative investigations that are addressing either the same or similar research questions, basically. The job of the researchers that conduct systematic review, that conduct meta-analysis, is first of all to gather all available evidence on that particular research topic, and this is done through a systematic review of the literature. We extract all the statistical findings from the eligible studies, and then we apply particular statistical methodologies to integrate and compare the studies, and at times actually find evidence of associations or patterns of findings that are not immediately apparent, basically, when we are considering single studies in isolation. So we conducted the first meta-analysis of this literature. We aim to review all available studies that consider the impact of different forms of childhood traumas, childhood adversities in people in the context of psychosis. So childhood sexual, physical, and emotional abuse, childhood neglect, both physical and emotional, bullying, and the experience of parental death. It was a major piece of work. It actually involved the screening of over 27,000 sources, basically, and ultimately led to the identification of 18 case control studies, eight large population-based cross-sectional studies, and crucially also 10 prospective studies that could be informative of the relationship between trauma and psychosis. And the findings ultimately indicated that there was a consistent and actually well-replicated relationship between trauma exposure and the risk of developing psychosis. And that on average, when people are exposed to adverse experiences, potentially traumatic experiences in childhood, their risk of developing psychosis increases over threefold. And this is the average relationship. But actually, this relationship is actually more complex than that, and actually the risk of people the risk of developing psychosis actually increases dramatically when people are exposed to multiple or repeated traumatic events, basically. Yeah, and the statistical effects basically were so strong that using some other statistical techniques, basically we estimated that up to a third of cases of psychosis could be actually potentially be attributable to the impact of the risk of childhood trauma as a risk factor for psychosis. More on that actually is so this idea that cumulative trauma might lead to worse or increased risk for the development of psychosis is this idea of dose response effect. So this effectively means that at higher levels of victimization, so for example, the higher the number of childhood traumas you have experienced, the chances of developing psychosis and your chances of a negative future prognosis increases correspondingly, basically. And this is a very important marker for recognizing potential risk factors in epidemiological data. And in the 2012 meta-analysis that we published already, the majority of studies that had sufficient data to test for these dose response patterns actually identified a dose response relationship. And this is just an example to give you an idea actually what the potency of this dose response relationship. So in a study conducted by Mark Shevlin in 2007, using a large American epidemiological data set, they found that when people are exposed to one type of childhood trauma in childhood, their chances of experiencing psychotic symptoms later in life increased over 2.5 times, but actually when they were exposed to 5 different types of childhood trauma, they were 53 times more likely to have experienced to experience psychotic symptoms later on in life. So it's a massive jump. It's actually a statistical effect of the magnitude of what we see between smoking and the risk of developing lung cancer. And we all know about, the importance of reducing exposure to that particular risk factor. So this meta-analysis actually was a little bit of a watershed moment for the literature, basically. It came out exactly at the right time when people started to get again interested in the impact of this kind of environmental exposure to the risk of developing psychosis. And in fact, it's been cited over 2,500 times since its publication 10 years ago. And since then, actually, the literature has exploded. So the literature on trauma and psychosis now has become mainstream, basically, whereas it was relatively niche until 10, 15 years ago. And we are actually I'm actually involved in an updated meta-analysis that is tackling exactly the same problem in collaboration with researchers in the Netherlands. Now we found that there are 221 eligible studies for this meta-analysis rather than 41 in just 10 years ago. So yeah, the literature is literally increasing exponentially, basically. But what does it all mean when it comes actually to the difficulties of people who are living with both early signs of psychosis and also, fully formed psychotic symptoms that are causing them distress and impairment? Can we use knowledge about trauma actually to understand what happens to these people over time? Does trauma have a prognostic value for people with psychosis? And I'm going to start actually with the ultra-risk group, these people with early signs of psychosis that have not yet, developed into fully formed difficulties. So exactly like in the broader, psychosis research literature, the numbers of studies that are looking at the impact of trauma in people with an ultra risk is increasing steadily. There are now 4 different systematic reviews, all confirming effectively high prevalence of trauma, and especially childhood trauma in people with an at-risk mental state. Levels of trauma exposure are higher compared to non-clinical controls, people that are not meeting the ultra-risk state, and they seem to be particularly high for certain type of certain type of traumatic experiences, such as emotional abuse, physical abuse, and bullying. It's estimated actually from meta-analysis that have been conducted on this literature that up to 90% of people with an ultra risk for psychosis actually have experienced some form of childhood trauma when growing up. And this is data actually from our lab as part of a study called Reducing the Risk for Psychosis by Targeting Trauma, or RESTART, in which we are looking in more detail at the impact of trauma and psychosis, trauma on the at-risk mental state, which is another term for the ultra-risk for psychosis. And it's just to give you an idea of the really difficult and highly prevalent experiences that these young people that are actually at the same age of many people in the room today, the average age of our sample is 20 years old, are reporting to us, basically. So there is still a small minority of people that do not report any trauma in childhood. It's about 12% in our sample. But actually, the majority of people actually that are reporting trauma are reporting an history of multiple and repeated traumatic events, on average 9 in our data. They have incredibly high levels of exposure to different types of interpersonal traumatic events. Almost 50% of the sample is actually comprised by survivors survivors of childhood sexual abuse. Almost 85% of the sample have experienced emotional and psychological abuse, etc. They are all, reporting absolutely horrific and multiple repeated histories of traumatic events. And crucially, they are all telling us that the traumatic events they experienced are still influencing their mental well-being in the here and now, their current mental well-being, with very high level of rated the impact on a scale from 0 to 10. They rated the impact of their traumatic events on their current health as 8 on average. Yeah. So what is the impact of trauma in this particular group, basically? So actually, it seems from different studies, basically, different studies that have been conducted in this area, that trauma in itself is not a particularly strong predictor on whether someone will transition to psychosis in the future or not, whether they will develop a first full-blown episode of psychosis. However, trauma seems to be associated with a number of important clinical correlates, clinical impacts, such as more severe prodromal symptom of psychosis, more severe functional difficulties, a range of comorbidities, and also substance misuse and other health risk behavior. And these are all factors that can increase someone's probability of developing future psychosis. In particular, the first two factors, the attenuated psychotic symptoms and the functional impairment, that seems to be both strong, quite well related to trauma, and also we know these are the most robust predictors of whether someone will transition to a diagnosis of a psychotic disorder in the future or not. So trauma is effectively playing an indirect relationship in determining whether someone transitions from an ultra-high-risk status to a first episode of psychosis. And we are looking into in more detail into this potential pathway as part of a prognostic study, so a longitudinal study here, and it's actually the first longitudinal studies, proper longitudinal studies I'm actually conducting, that we are conducting in the UK in collaboration with Professor Alison Young, which is actually the professor based in Australia that came up with the notion of the ultra-high risk for psychosis concept in the first place. The idea of this project is actually to try to identify the factors that are most reliably predict whether someone will become psychotic in the future or not, if they also have they meet criteria for an ultra-high risk for psychosis, and develop a refined prognostic model which we could implement in routine practice in all mental health services that see this clinical group, basically, in the UK. It's actually quite a complex project in the sense that it had multiple phases. The first phase actually involved another methodology that I quite like, which is individual patient data meta-analysis. So I mentioned meta-analysis before. Individual patient data meta-analysis is somewhat similar to the typical meta-analysis that you can see out there, that is most often published in the scientific literature. But the key difference is that instead of working with data that is extracted from published articles, we are actually going back to the original investigator and ask access to their original data set. And we then work with the original data set and combine them into a single analysis. And this creates much more statistical power and opportunities actually to really mine the data for relationship and effects that might have been missed in the single investigation, basically. It's sort of like more of a mega analysis rather than a meta-analysis, basically. So we did actually this kind of work in relation to the psychosis risk in the ultra-high risk group by getting data sets from 16 different countries with over 3,700 participants. And basically, through reanalyzing this data set, we came up with a list of variables that was most significantly linked to the risk of developing future psychosis if someone is already meeting the ultra high risk state, the UHR state. So several are not surprising. So it depends a lot on how severe their symptom of psychosis, both positive and negative symptom of psychosis are. There are some demographic variables that seems to be important, their level of functioning, both social and occupational. Neurocognition is an important factor. So whether people are displaying certain subtle cognitive deficit, if you want, in the domains of processing speeds and verbal memory. Levels of depression, and of course, childhood trauma. Given its prevalence as a risk factor as a factor in the at-risk mental state and in people with psychosis. And now we are at the third stage of the study. We don't have findings yet, but effectively we are completing what is the largest prognostic study of psychosis risk that has ever been conducted in the UK. We already recruited over 650 participants. We're hoping by October to get almost to 800, which is our target, and through that hopefully understand whether the variables that I've just illustrated really help us to understand and to identify people that are at the highest risk of developing psychosis, so that we can then provide them preferential access, no, preferential access is not the right word, expedite access to preventive intervention for psychosis, intervention like cognitive behavioral therapy, which we know can reduce someone's likelihood of developing future psychosis. Okay, so what happens after first episode of psychosis is someone has got an history of trauma. The exposure to traumatic life events has actually been linked to a wide range of adverse outcomes in people with psychosis. For example, greater risk of hospitalization, greater use of emergency services, A&E attendance, antipsychotic treatment resistance, and a lot of different other outcomes, social functioning, etc. Actually, there are already a number of meta-analyses that are appearing in the literature that are bringing together all these findings. The one that are most consistent are related to the severity of core symptoms of psychosis, such as hallucination and delusion. So is what I mentioned before. The more people are exposed to traumatic life experiences, the more severe their symptom of psychosis are. And there is already a meta-analysis published in Schizophrenia Bulletin by Bailey et al. There are also some effects on neurocognition. Yeah, so we know that cognitive difficulties are an important factor in schizophrenia and psychosis more generally, but actually these effects are relatively small. So actually it's childhood trauma is clearly not the main driver of the cognitive difficulties that we see in people with psychosis. And so far, I've actually focused a lot on the impact of childhood trauma, and that makes sense because, at times researchers are interested in more understanding whether early developmental experiences can have a long-term impact on the trajectory of people. But that doesn't actually mean that traumatic events that are happening later on in life do not have an impact. As a matter of fact, actually, people with psychosis are often exposed to a range of adverse life circumstances and events as a direct result of the fact that they are becoming ill, that they are becoming psychotic, but also as a result of the treatment that they receive from services. So experiences of coercive hospitalizations, forced hospitalization can be traumatic. When people are hospitalized, they are often, put in restraint if they are highly agitated, or if they are given high doses of effectively tranquilizer, antipsychotic medications against their will. People often lose friendships, valued relationship, work, years of education. They are more vulnerable to exploitation and violence after they become ill and they develop a severe mental disorder. So effectively, when we are working with people with psychosis, there is an accumulation of multiple potentially traumatogenic events, and all these are having an impact on the well-being and chances of recovery of the people that we see in our clinics. And this is a little bit of a, sort of very basic sort of conceptualization that I try to keep in mind whenever I'm working with someone with the lived experience of psychosis. Whenever we are working with this population, we are always presented with people that are likely to have a multi-layered trauma history that is impacting on their well-being. There will be experiences of childhood adversities. There will be the traumatic impact of becoming psychotic. Actually, the experience of symptom of psychosis in themselves can be traumatic for people, like terrifying symptoms, hallucinations. Iatrogenic impact of stigma and discrimination, adult experiences of trauma, etc., basically. So in the majority of people that access services, at least one of these things will be present, basically. Trauma is endemic in people with psychosis. And perhaps not surprisingly, actually one of the main impacts, and now, or fortunately now, well-recognized impact of trauma in people with psychosis is the prevalence of comorbid post-traumatic stress symptoms. And this is particularly relevant at the early stages of psychosis. So this is a couple of meta-analyses by other research group. In the first one, by Rodriguez and Anderson, it was found that after a first episode of psychosis, approximately 1 in 2 people experienced clinically significant PTSD symptoms following a first episode of psychosis, and 1 in 3 actually met the criteria, the diagnostic criteria for post-traumatic stress disorder. So their post-traumatic stress difficulties are so high that they are potentially diagnosable. And in the second meta-analysis, actually, they found that between 14 and 47% of service users with early psychosis, actually, when you look at the causes of their post-traumatic symptoms, they were often related to something that happened to them as the result of becoming psychotic. So the intrusive memory, the flashback that at times they report, are not related necessarily to experiences of childhood trauma. They are at times related actually to what happened to them in hospital, or the experience of hearing voices, the voice of the devil for the first time. So, these internal experiences and also external experiences that people describe can be traumatogenic in themselves. And more recently, actually, we also shifted our focus not just to PTSD in general, but more specifically to a alleged subtype of PTSD known as complex PTSD. And our research group is actually, this is the first actually publication on specifically on this topic that has appeared in the literature. But effectively, complex PTSD is a notion that has been around for quite a long time in the applied clinical literature. It was proposed by a psychologist called Judith Herman at the beginning of the 90s as effectively as a suggestion that the typical diagnostic criteria that are used to diagnose PTSD do not fully reflect the more pervasive difficulties that many survivors of prolonged complex trauma are reporting. Yeah. So this notion has been around for a long time, but it's only been recently recognized in diagnostic classification system, in particular the ICD-11, the International Classification of Disease version 11. Complex PTSD is effectively defined, comprises the same core symptoms of PTSD, re-experiencing symptoms such as flashback, intrusive thoughts, avoidance, and hyperarousal, but also there are additional more pervasive symptoms which are related to very profound negative beliefs about the self that the person has developed as a result of their traumatic events, emotional regulation difficulties, and difficulties in interpersonal relationship. And we always thought that this concept, complex PTSD, might be particularly applicable to people with psychosis because we see these disturbances in self-organization, as they are called, continuously in people with lived experience of psychosis. And it's a particular type of presentation that is assumed to be more prevalent in people with complex trauma histories, like experiences of childhood abuse or experiences where escaping from trauma is impossible or difficult to achieve, which actually sort of resonate with the histories of the clients with lived experience of psychosis we see. So as I mentioned before, we conducted the first study looking at how prevalent is actually complex PTSD in people with psychosis. And actually we found that is, not surprisingly, much more prevalent than simple PTSD. So although, of course, a good chunk of people with psychosis do not have experiences so severe to meet threshold for a trauma-related diagnosis, about 50% does, and actually out of this 50%, 40% are actually meeting criteria for complex PTSD. And we're actually seeing in our findings, more recent findings for the RESTART trial, exactly the same pattern in people with an ultra risk for psychosis, which is not surprisingly given their trauma histories, but poses a problem because complex PTSD is assumed to be more difficult to treat than single event traumas that leads to simple PTSD. I don't think PTSD is ever simple, by the way, but it's a way to discriminate between the two. Something very important to bear in mind, and why we think actually this correspondence between PTSD and psychosis is also important, is because when we really look at the phenomenology of PTSD symptoms and core symptom of psychosis, we often find more similarities than differences. And there is perhaps they effectively lie on a continuum of decontextualization. On the one hand, the symptoms of common psychological consequences of trauma are often readily recognized by both practitioners and patients as being a result of trauma. Yeah. People with psychosis don't often do that, yeah, despite the fact that actually many of the experiences and symptoms they present important similarities. So, for example, as I mentioned before, a common consequence of trauma is the experience of re-experiencing symptom, intrusive memory, and also intrusive somatic perception, decontextualized images, basically, etc. And they correspond very neatly actually to a range of anomalous perceptual experiences, including hallucinations that we see in people with psychosis. In trauma, we have an intense sense of current threat and hypervigilance, and we see the same in people with psychosis, but often we call it, a threat-related appraisal, a sense of paranoid feelings, paranoia, etc. Yeah. So there is an increasing psychological literature actually that is looking at both the phenomenological correspondence between these different symptoms that we recognize as being trauma and symptoms that we recognize as being psychotic, and whether actually the two are related to each other, and perhaps they are different names for effectively the same underlying processes. Another interesting finding that has been, I find, actually highlighted in the literature is that at times the content of symptom of psychosis either directly or thematically matches the lived experience of traumatic life events of patients. Yeah. So, for example, it's actually quite common in people that have experienced extreme forms of, for example, sexual abuse, that actually the voice they describe is actually the voice of the abuser. Yeah, or a critical voice that is actually, that is actually commenting to elements related to the abuse, for example, their sexuality. Yeah, and there are multiple examples of this, both thematic and direct link between psychotic symptom and trauma in the literature. So, okay, are the emotional and psychological consequences or impacts of trauma important mechanisms in the maintenance of psychosis then? So this is another element of this literature that has been tackled with different kind of research methods. And it's a very important question because actually in order to say that trauma is a relevant risk factor for the development of psychosis, a number of criteria that have actually been proposed by this chap, Austin Bradford-Hill, need to be met, and a lot of them are actually met by the evidence that I've already illustrated today and the evidence that we consider in the 2012 meta-analysis. There is a sufficiently strong association, statistical association between trauma and psychosis. The relationship is relatively consistent. It's temporal, so trauma seems to be preceding psychosis in longitudinal studies. There is a dose-response relationship, but ultimately we need also to make sure that there are plausible mechanisms mechanisms linking the two constructs, basically, regardless of whether these are psychological or biological in nature. And many of you will be familiar with a particular statistical approach that I think is still is taught in undergraduate programs. It certainly was when I was a student, which is called mediation analysis, which is a statistical approach effectively to try to understand whether an independent variable is influencing a dependent variable in an indirect way through a mediator. Yeah. So, for example, in the context of this literature, whether the effect of trauma on the severity or the presence of hallucinations is actually perhaps explained by a third variable. So the trauma is actually causing a particular psychological state or particular psychological process, in this case, dissociation, which is a common impact of trauma, and this in turn is influencing the severity of hallucinations. So actually this is a very popular statistical approach. Now more sophisticated elaborations of these basic models are available through structural equation modeling, for example, or also the use of other statistical approaches like network analysis. But the vast majority of researchers out there have applied mediation analysis to try to identify potential mechanisms that are linking trauma to psychosis. So this is an example of one study we conducted in which we found that the association between trauma and the severity of positive symptom of psychosis, hallucinations and paranoia, is actually explained by the indirect effect of the severity of core post-traumatic symptoms and this characteristic feature of complex trauma, the disturbances in self-organizations that I mentioned before. But this is just one example of many, many studies of this kind, basically, that have several done by my research group and also by many other by the other groups, especially in the UK, but also in North America, to the point that already in 2018, we managed to put together a meaningful systematic review of this literature in which we identified a number of candidate and common psychological consequences of trauma that might explain why trauma is linked to greater occurrence and greater severity of symptom of psychosis. So these are the presence of, the dissociative experiences, intrusive trauma memories and other PTSD symptoms, negative beliefs about the self and others that people might develop as a result of their traumatic life experiences, a range of emotional regulation difficulties, and also affective symptoms like elevated anxiety. There is an important affective route into the risk of developing psychosis, and also difficulties related to attachment, especially when trauma happened early on in life. These, of course, are not findings just of our own lab. This systematic review has already been replicated independently by two other research groups with convergent findings and suggesting that these processes might be not only important processes to understand this relationship, but also important potential treatment targets in people with psychosis. We can actually target these experiences, these processes using psychological intervention. To further understand whether some of these mechanisms might be indeed important in the lived experience of people with psychosis, other research methods can be applied, and this is a particular method that I'm particularly fond of, to the point I've published with some colleagues a book on that, on the application to mental health research. So shameless promotion of my book, please buy it. Yeah. But it's called the experience sampling method. Yeah, the experience sampling method is essentially a structured diary study that it's effectively try to understand how people behave, how people think, how people feel in the context of daily life. Yeah, so it effectively works with a mobile device, effectively, that is programmed with an app that is programmed to beep multiple times per day at quasi-random intervals, and at any time point, people have to report on their symptoms, on their experiences, according to whatever research question you are interested to investigate. So effectively, this method provides a very intensive longitudinal data set of what happens to people's symptoms over the course of their daily life. And you can ask questions like, how often are people hearing voices over the course of daily life, but also most importantly, what is predicting the occurrence of particular symptom over the course of daily life? Are there other psychological state, other psychological variables, specific environmental context that are more likely to bring about symptoms? Yeah, and this is a method that has been applied to all sorts of questions in relation to psychosis. Amongst other things, we applied it to psychological phenomena, psychological processes that are likely to be influenced by trauma and adversity. And in all cases, we found actually that these processes seems to be associated with a higher likelihood of occurrence of psychotic symptoms in the daily life of patients. So for example, when dissociative states increase over the course of daily life, people are more likely to report paranoid thoughts and hallucinatory experiences. Negative beliefs about the self, the same. They are very strongly associated with certain symptoms of psychosis, such as paranoia. The more someone starts feeling bad about themselves and is in this state effectively of distress, the more likely is that they make paranoid attributions about other people. Other people must think I'm bad because I'm feeling I'm a bad person. Yeah, and also insecure attachment-related cognitions, emotional regulation difficulties, etc. Yeah, currently I'm actually involved in the one of the largest, the largest experience sampling study specifically designed to try to understand better the role of different trauma-related variables in people with psychosis. So this is part actually of a trial that I'm going to mention in a couple of minutes, a little later, called the STAR trial, in which we effectively try to understand better whether all these different, different trauma-related processes that we have considered in different investigation in isolation actually interacting with each other in order to bring about symptom of psychosis in the daily life of patients, but also whether these processes are actually responding to psychological interventions. So this is effectively a study that is embedded in a clinical trial of trauma therapy in people with psychosis, and we try to see, can we see these changes in this important variable in the daily life of people? Okay, I've talked a lot about data that are self-report, that are questionnaire, that are interviews, and I'm sure many of you are interested also in the impact of other processes that are perhaps more biological or brain-related in nature. Unfortunately, I'm not an expert of this area, and this is something I've only just started to dip my toe in. So out of respect to the neuroscientists in the room, I'm not going to talk too much about this, basically. But something that is recognized is that whereas there has been a lot of progress in the development of knowledge related to the psychological mediators of the trauma and psychosis relationship, there is still a relative paucity of knowledge related to biological mediators and potential brain processes involved in that relationship. So considerable more work actually needs to be conducted in this area. I have the privilege actually to be involved in some of this work, again, as part of the STAR trial, in which we are actually trying to link these experience sampling data, so data on daily life of symptoms, to particular structural and functional anomalies detected using MRI in a large sample of people with psychosis. Hopefully, this will enable to bridge a little bit more, the lived experience of people with psychosis with actually, biological fMRI data, basically. Okay, last bit of my talk, last few slides. So ultimately, the trauma is important. There are all these mechanisms. Can we do something about it? By targeting trauma and psychosis, can we make the difficulties that people are struggling with better? And the answer is, we are still not sure, but all the signals are promising. Yeah, there have been a number of breakthroughs in the field of psychotherapy for psychosis in recent years. In terms, a lot of researchers have started to apply evidence-based psychological intervention for PTSD to improve post-traumatic stress disorder, comorbid post-traumatic stress disorder in people with psychosis. And this has led to a range of positive outcomes. First of all, we know that post-traumatic stress disorder can get better. So this important impact of trauma in people with psychosis can improve using the right interventions. And when we do that, actually symptoms of psychosis tend to improve as well. Yeah. So as a result of these encouraging findings, basically, there are a couple of current direction that clinical trialists are taking. The first thing is try to fine-tune evidence-based psychological intervention for psychosis, such as CBT for psychosis, to better target the psychological and emotional impacts of trauma that might be involved in the development or better in the maintenance of psychotic symptoms. And the other line of research is actually to adapt evidence-based intervention for trauma for as effectively therapies that can be used to potentially treat psychosis in its own right. An example of the approach of the first kind is something that we tried to do in Manchester, based on research we've conducted suggesting that dissociation is a particularly important process or psychological consequences of trauma involved in the maintenance of psychotic symptoms. We conducted a case series, effectively, a pre-post design study, in which we offered to 19 people, I think it was, with 19 trauma survivors with psychosis and an history of interpersonal trauma. We offered them effectively a form of CBT that was not just designed to help with psychosis, but was specifically targeting dissociative symptoms in this, in this population. And the intervention was designed in such a way that people had to work on dissociation first, and only if they passed that, they moved to work on their psychosis-related difficulties. And what we found is that even just after dissociation-related work was offered as part of the intervention, people actually reported a range of improvement, both related to their symptom of psychosis, hallucination and delusions, but also dissociation and other important clinical outcomes. And this is effectively was a small-scale study with other kind of other pilot interventional studies that have been conducted in the UK at the same time, eventually led to the funding of what is currently the largest clinical trial of trauma-focused therapy in people with psychosis, which is the STAR trial that I mentioned previously, which is actually led by Professor Emmanuel Peters at King's College London. And we just finished last month the recruitment for this trial, recruiting 300 people. But unfortunately, I cannot share any findings with you because we have a very long follow-up period, which is 2 years. So we won't know whether this work has worked for a very long time still. But yeah, this kind of research can lead to large-scale kind of clinical trials, basically, in due time. The other piece of work I've done is related to the adaptation of an evidence-based intervention for trauma called eye movement desensitization and reprocessing. And effectively, I've worked with a group of very gifted EMDR consultants in the UK to adapt this intervention to target directly trauma-related psychotic symptoms in people with early psychosis following a first episode of psychosis. Again, I'm mindful that I'm running out of time, so I'm going to rush a little bit through this, but effectively we have just completed a clinical trial, in a pilot clinical trial of this intervention with 60 service users with first episode psychosis. Half of them were randomized to receive our EMDR for psychosis treatment, and half of them to their usual treatment. And we followed them up for 12 months. And actually, as a result of treatment, there were promising signals of efficacy across a range of important outcomes, but most importantly, the severity of the psychotic symptom, of the general symptom of psychosis. So actually by adapting trauma therapies that are actually directly targeting emotional and psychological consequences of trauma, there seems to be a signal that we can improve psychosis, but still more work needs to be done in this area. So this was the last thing that I wanted to mention to you all. Hopefully, as a result of what I covered today, you have a sense that different research methods that you are learning now can be applied to tackle complex problems, basically, when we are actually using them in tandem and also as a research community rather than just single investigators. And hopefully, you don't think that I'm completely delusional by thinking all this. Yeah. Thank you so much. Yeah.
Thank you. S'il y a des questions, s'il vous plaît, il y a des micros. Ou si vous êtes au centre, je peux vous passer le micro. Sinon, vous levez pour le micro sur le côté. Any questions? Use the mic, please.
Thank you, Professor. So my name is Sarah. I obtained my bachelor in psychology at University of Montreal, and I now have a master in a research master in psychiatric medicine. We actually received a postdoctoral student from King's College, Lucy Chester. I don't know if it's familiar, but she was working also with the concept of high-risk patient. I had a question regarding your I-PACT slide,
Study.
You were looking at some variables. I was a bit confused. How do you identify high-risk patient?
Yeah.
Are these people may have already experienced a first psychotic episode? Could you give us more information about the concept of high-risk patients?
Yeah, absolutely. So basically, the reason why at times I get confused with the high risk, ultra high risk terminology is actually we don't use it in the UK. We use a terminology called at-risk mental state. Yeah, UHR is actually something that is much more used in North America. And we basically use a specific validated instrument, which is called the CARMS. It's called the Comprehensive Assessment of the At-Risk Mental State. And it's effectively a clinical interview in which you are asking for the presence of symptoms of psychosis that are then systematically rated for their severity and phenomenological characteristics, as well as for their duration and frequency. Yeah, and that there are specific thresholds for each symptom or symptom dimension that will tell you whether the person has already transitioned to a first episode of psychosis or not. Yeah, so the interview actually applies to the past year. Yeah, and then as part of the assessment, you also need to check historically if the person in the past has experienced above threshold kind of experiences. In addition to that, we of course check clinical records of people. So if people have ever been prescribed antipsychotic medication over a certain threshold, basically we automatically regard them as not an at-risk mental state anymore, but over transitioned already. And also any information that might be suggestive that they might have had a treated or untreated episode of psychosis at any point in their life. Yeah, so there are specific manual and assessment that we follow that are very well validated. Yeah.
So there are people who score right under the threshold, basically?
Correct, yeah. And as soon as they move up the threshold, you regard them as first episode psychosis, and they should receive recommended treatments for first episode psychosis.
I think there's a question there.
Thank you for your presentation, Dr. Varese. My question, so I have one question and a sub-question. Is it the traumatic event itself that's triggering the psychosis in your PTSD situation, or is it the changes on the brain structures from the PTSD and the trauma accumulated over life? And the sub question would be, in a non-ethical world, could you trigger psychosis by bringing back the traumatic event?
Yeah. Okay, let's tackle the first question first. So the Just to check if I understand the question, you're basically asking whether the traumatic events itself can trigger PTSD symptoms in people with psychosis, or whether it's the traumatic event or the brain changes, basically. Yeah.
For the initial psychosis.
Yeah. That is going to then manifest as psychosis, basically. Well, that's a very complex question, and I'm not sure if I have the full answer, basically. It's very likely, basically, that effectively what happens to people as a result of the traumatic events has got both psychological, and and brain functioning implications, basically, and the two might be interrelated to each other. So, for example, if someone is effectively in a situation in which they are forced to continuously suppress, traumatic memories, basically, or the experience of what's happening to them in the here and now, probably that's going to also impact on, potentially brain structure and brain functioning that is going to have lasting effect and is going to impact how you react to stress later on in life, basically. So it's probably a combination of both. I don't think it's certainly not a stimulus response kind of effect. It's mediated by a lot of psychological, for sure, and probably a lot of biological processes as well. So that's your first. Yeah. Second one, which was, in an unethical world, can we trigger psychosis? By reactivating the trauma. Okay, yes and no. Okay. How do I answer that question? Yes, in the sense, we know that in trauma therapy, when you are actually starting what it's called relieving work, which effectively means some level of exposure of the patient to the trauma memory, actually the intensity of symptoms momentarily increases. But this is typically short-lived and is managed well in the context of therapy, but there is a little bit of a shift in difficulties, and this is common in trauma therapies, not just in psychosis, but also in people with PTSD, and it doesn't lead to severe adverse reaction, basically. So hypothetically, it's possible, and certainly the impact of re-victimization works in that way. So it's actually not quite unusual to see people that had a lot of childhood adversities, then they were fine for a long time, then something then happens again that was consistent with what happened to them in the past, and then triggers a breakdown, basically. So certainly, yes, I wouldn't do it as a research study.
Thank you.
See, thank you. There's a question over there.
Hi. Thanks for the presentation. It's fantastic to see that we're shifting away from just individual difference and more into the social causes of mental health. My question is about whether you've seen if there's a difference between individual versus shared collective trauma. Because on the one hand, I can think that having a collective trauma means that it's shared, so that there's potentially more social support, or at least there's I'm not alone in my experience. But at the same time, if it is a collective trauma, then everyone is depleted. So have you seen anything in terms of differences in individual versus collective traumas?
I was actually thinking originally very much along the same lines, that perhaps actually the idea of collective trauma is somewhat protective, and unfortunately changed my mind. Something that is quite eye-opening is when you're comparing the rates of psychosis in refugee populations and suitable controls, basically. So being a refugee is certainly a shared traumatic experience, but just the sheer amount of awful stuff that happened to them, it's bringing about very severe responses, basically. In the context of natural disaster is a little bit different, perhaps, actually. But when it comes to severe interpersonal trauma, I think the fact that it's collective is not sufficient, basically. Thanks.
Merci.
Hi, my name is Sarah. Thank you for this presentation. I have two questions that are not really related. So I'm going to start with the easy one. You mentioned in the your meta-analysis, the individual participant data, that you have now 26 studies from 16 different countries. And is there any ethical issues for sharing the data again when you're going to collect them again from the authors, just out of curiosity? Like how difficult and complex is all this process? Because 16 different countries and universities.
It's difficult. Yeah, first of all, you need to convince the investigator that it's important that they share the data, and then you need to convince their institution that it's fine to share the data. And these things have become increasingly more complicated over time in terms of signing data sharing agreements between different institutions, especially when you are involving different national partners, basically. But it's not impossible, and not all countries are actually requires that, basically. In relation to whether it's ethical, so this has been a of important debate actually related to secondary data analysis in general, basically. And ultimately, the principle is that if you are using the data exactly for the same purpose for which the data were originally collected, it's fine, because you're still using the data in a way in which people have provided informed consent to, but you're a different analyst. And what I'm doing is exactly what all these original studies did, which is trying to understand who is becoming psychotic, who is developing a first episode psychosis later on in life, basically. Yeah, there's a literature actually in IPD meta-analysis and the ethical aspect of that. Yeah.
Can I ask my? Yeah. Okay. So my second question is more clinical. So I've read in some reviews that clinicians nowadays, or practitioners, tend to be afraid of treating trauma or the stress-related symptoms of trauma in the psychotic population, or for people with psychotic disorders. First of all, by fear of exacerbating the psychotic symptoms, and second, because they think it will increase the risk of dropout. And so my question is, did you experience something like that in your trials? And to also elaborate more on this, I've read some meta-analysis that gives some contradictory results about the trauma-focused treatment for psychotic disorder. Some of them say that it enhance or it's really it's good on. Oh, sorry, I lost my words. So some of them, there's two meta-analyses, one in 2017 and one in 2018. One of them say it enhanced the stress-related symptoms, and the other said it had no effect on the stress-related symptoms, but both said it was a good effect on the psychotic symptoms. So I think it's a bit confusing, just to hear your clinical experience about this.
Yeah, and research. So I probably need to trace back to the different questions. So starting with the last one, basically. So actually there are now 4 or 5 different meta-analyses of trauma-focused treatment in psychosis. And it's true that some have contradictory findings, especially the Sin and Spain kind of meta-analysis is the one that was most sort of skeptical, basically, or inconclusive findings, basically. The point is we are continuously sort of publishing trials, basically, so the literature is expanding quite rapidly, and the first proper trial of trauma-focused CBT or trauma-focused treatment is only a few years ago, basically. Yeah, so part is due to the accumulation of evidence. The actual convergence of these 5 systematic review and meta-analysis is that there is good effect for the treatment of PTSD, so quite good effect size is there. Less promising for the treatment of actually psychotic symptoms in themselves, but we need to bear in mind that these interventions were not designed to improve psychotic symptoms, basically, and they were actually at times conducted in population where psychotic symptoms were fairly low. People were not necessarily symptomatic, so we don't actually expect a good treatment effect there. Yeah. Then I need to trace back to the previous question. Yeah. So yes, concerns about the use of exposure treatments are really common among psychological practitioners. We continuously come across to people that actually are good CBT psychosis therapists, CBT for psychosis therapists, but they are not used, for example, to use trauma-focused techniques, and they have concerns about the application of these techniques to their clients, basically. What we actually find, again, is that, yes, trauma therapies are intense. Yeah, they can lead to this slight exacerbation of symptoms in the session. Basically, the voices might become a little bit more intense and aggressive, but they can be managed. Yeah, in all the trials we've done, we haven't had a single serious adverse event as a result of trauma therapy. Basically, yeah, but they are not nice therapies to have. Thinking about the most horrific thing that happened to you. Yeah. So does it answer your questions? By the way, yeah.
Okay. Il y a une question ici? Oui.
Thank you again for the presentation. My question is in respect of trauma and psychosis, of course. You highlighted that other disorders such as BPD or depression can have psychosis characteristics. I was wondering if you had any insight on dissociative identity disorder, since it's also considered to be linked to trauma, and psychosis can include dissociative experiences as well. So do you have any insight on that?
Yeah, insight, I'm not sure. But actually, there is actually a strong debate, I suppose, and amongst different academics, and people are a little bit split on the position that actually some people think that certain forms of schizophrenia are effectively undiagnosed DID. Yeah, and effectively any kind of trauma-related presentation related to hallucination and stuff like that might potentially be that, basically, and other people that really sort of reject that strong position, basically. In reality, symptoms of dissociation, both in terms of dissociative detachment and dissociative compartmentalization, which is effectively what DID is, and symptom of psychosis overlap. And there are actually quite interesting network analyses that have been conducted in different kind of patient group, showing that, interrelationship between the two symptom clusters. Ultimately, I have to confess, I'm not a big fan of rigid psychiatric diagnosis and diagnostic boundary, basically. So I do think that there is, a lot of overlap in processes and underpinning mechanisms, basically. Yeah.
Thank you.
Une autre question? Oui, ici.
Thank you for the presentation. It was really interesting, and yes, do I need to? My question is with your last slide and your, I think, not at all delusional beliefs. What are your thoughts or your clinical recommendations on systematic screening for childhood maltreatment in therapy in general, but maybe with psychotic in clinics for? Because there's a debate in childhood maltreatment whether we should or not.
Yeah.
Sort of pitfalls and advantages of that.
Yeah, I'm pro routine screening, routine trauma inquiry, and it's simply because we know that unless we put system in place so that the question is asked, basically, many people will never be asked. Yeah, and the insight from research is that this kind of assessments about childhood adversities and trauma are very well tolerated by people with psychosis, basically. It needs to happen at the right time. I wouldn't do it in the middle of a crisis. I wouldn't do it at the first time you see a client, basically, or something like that. There needs to be, a relationship, building element and other factors involved. But I'm absolutely positive that supportive, basically, of routine trauma inquiry.
And what would you use? Do you use a systematic tool or just clinical interviewing?
Well, no, we do use systematic tool, again, because we think otherwise you go for the preference of what's your pet traumatic event. So currently in all our trials, and actually in clinics, increasingly we are using an instrument developed by Amy Hardy called the TALE, Trauma and Life Experiences Scale, which has been an instrument actually developed in collaboration with people with lived experience of psychosis, so including the traumatic events that are most common in the population. And it's been developed in a way that can be, we found it very acceptable to people with psychosis. Yeah.
I actually think we're out of time. This was wonderful. Thank you so much. Merci beaucoup, Filippo.
Thank you so much.
Michel?
Yes, thank you very much for generously sharing this quite important and very impressive body of work with us. Thank you. OK, donc, avant d'aller réseauter un peu, oh, j'ai pas mes lunettes.
Juste faire jusqu'à photo, demander aux gens s'ils peuvent venir sur la scène. On va prendre la photo pour les premiers cycles supérieurs et au bourse, puis après ça, l'ensemble.
OK. Oui, elle est là. Ils sont là. OK, donc on va procéder avec, on va commencer par les prix qui vont être remis pour les meilleures présentations étudiantes. Et ensuite, on va annoncer les concours de l'enseignant, l'enseignante la plus inspirante. Donc, je vais commencer par nommer les 6 personnes qui ont remporté les prix pour les meilleures communications orales et affichées. Je vais vous demander de monter ici et on applaudira ensuite tout le monde. On prendra une photo et on va passer au prochain. Comme ça, on ne passera pas 30 minutes à vous remettre les prix. Alors, je commence par les prix pour la meilleure communication orale, premier cycle. Donc, ce sont 2 prix de 350 $ chacun. Rosalie Gravel et Laurie Tremblay. Donc, vous pouvez venir. Ensuite, on applaudit après. Ensuite, est-ce que Rosalie Gravel et Laurie Tremblay sont peut-être partis? Oui, je vous invite à venir ici. Ensuite, meilleure communication affichée premier cycle, aussi 2 prix de 350 $. Maria Chamas et Nicolas Hardy. Vous pouvez venir. Ensuite, meilleure communication orale, cheminement en or, un prix de 350 $, Florence Léonard. Et meilleure communication affichée, cheminement en or, un prix de 350 $ aussi, Annabelle No.
Les prix spéciaux. Il y a juste celui-là, c'est un certificat cadeau.
OK. Fait que bon, on a les prochains 8, c'est ça. Donc, il y a 8 autres prix à décerner. Donc, je vais nommer les 8 personnes. Je vous invite à monter. On fait la même chose. Donc, maintenant, ce sont les prix pour meilleure communication orale au cycle supérieur. Donc, 2 prix de 350 $. Margot Bédu et Clara Soulez. Donc, je vous invite à monter. Meilleure communication affichée cycle supérieur, 2 prix de 350 $. Gabriel Leclerc et Marc-Antoine Axam-Ouellette. OK. Il y a un prix aussi de l'Association québécoise des neuropsychologues pour la meilleure présentation dans le domaine de la neuropsychologie clinique, 350 $ aussi. Margot Elgot. Elgo? Oh, Marc, excuse-moi. J'ai pas mes lunettes et je lis de loin. Ensuite, le prix Krista Hyde pour la meilleure présentation dans le domaine de la neuroscience, neurocognition musicale et la perception auditive, aussi un prix de 350 $. Juliette Fortier. Et le prix Spirale pour la meilleure présentation au cycle supérieur dans le domaine de la neuropsychologie clinique. Donc, c'est un certificat cadeau de 250 $ pour une formation en neuropsychologie chez Formation Spirale. Léonie Labrec. Et le défi Kurt Lewin, qui est un prix offert par le professeur retraité Robert Hakoun pour la recherche d'intérêt théorique et pratique, donc Paul McNichol. Donc, Là, OK. T'as-tu mis les noms? J'ai le truc dans le visage. OK, maintenant, on a trois prix. C'est ça?
Ça, c'est classique. Ça, c'est le plus inspirant, parce qu'on a reconnu.
OK, excusez-moi. Donc, au premier cycle, on a deux personnes qui, ex aequo, ont reçu le plus de votes. En fait, je vous explique, excusez-moi, j'ai le truc dans le visage. Je vous explique que le concours des enseignants les plus inspirants est lancé par les associations étudiantes. Il y a plusieurs tours de vote, donc des mises en nomination. Et ensuite, il y a 3 personnes généralement qui se retrouvent dans les finalistes. Et il y a un vote final pour déterminer les finalistes. Puis cette année, je pense qu'il y a eu 500 votes pour la ronde finale de vote. Donc vraiment, merci vous tous pour participer en grand nombre. Et donc, il y a ex aequo cette année au premier cycle pour les chargés de cours les plus inspirants, Ghislain Giguère. Et Pascal Audrey Moriconi. OK. Parfait. Et donc, au premier cycle aussi, maintenant, le prix de la professeure la plus inspirante est décerné à Sonia Lupien. Sonia, je t'invite à venir. Si tu dirais un petit mot, bien sûr.
Tu veux-tu?
Non, c'est bon.
Je vais le faire pour Ghislain. Je voulais juste vous remercier et vous dire que si j'ai gagné ce prix-là, c'est grâce à vos ordinateurs et à vos cellulaires. C'est vrai? Parce que quand tu es en avant puis tu enseignes, je vois tous vos yeux. Et là, je sais, vous êtes intéressés, je le vois. Et à un moment donné, quand je dis quelque chose dans mon cours, et là, je vois tout le monde comme ça regarder son ordinateur et son cellulaire. Moi, j'en prends note dans ma tête, puis je me dis, OK, ça, il faut que je change de quoi l'année prochaine, c'est plate. Et donc, à chaque année, grâce à vos ordinateurs et à vos cellulaires, vous rendez ce cours plus intéressant. Je vous remercie.
Je reste pas loin, on va prendre une photo après.
Bonjour tout le monde. Je tiens à remercier les étudiants qui ont pris le temps de voter. 500 personnes, c'est quand même beaucoup. Ça me fait toujours chaud au cœur de recevoir ce genre de prix-là, même si je n'enseigne pas un cours très populaire, même si je vous torture un petit peu, puis vous le savez, puis vous le dites à vos amis, puis ils s'inscrivent quand même. Donc, merci beaucoup à tous.
Et pour terminer, l'enseignant le plus inspirant au cycle supérieur, Nicolas Pesan.
Alors, je sais que vous avez hâte au 5 à 7. Je suis plus nerveux de dire un petit mot ici que de donner un cours de 3 heures, mais c'est juste pour remercier les étudiants. Pendant la présentation, en fait, je préparais ce que j'allais dire. Puis, quand j'étais au doctorat, pendant ma formation clinique, il y a eu des profs qui m'ont marqué. Je pense à Conrad Lecomte, Mireille Cyr, des superviseurs aussi. Puis, dans l'expérience que j'avais avec eux, c'était plus qu'une formation académique. Il y avait l'impression de faire un voyage, puis c'était un processus de transformation personnelle. Là, clairement, je n'enseigne pas des statistiques, mais je m'étais dit, un jour, j'aimerais ça, faire vivre ça à des gens, ce que je vis dans ce genre de cours-là. Fait que ce prix-là est très significatif parce que c'est un peu une façon de me dire que ça a marché. Alors, merci.
Merci beaucoup pour votre participation et on vous invite à prendre un petit verre, à jaser, réseauter pour bien terminer cette journée.